All right. So we're going to, like I said, today's topic is a little bit of revision of the last two PPTs that we saw. And I also said that this is one of my favorite topics and very
You're
interesting.
muted, man.
Sorry, muted.
You're muted.
Okay, okay, okay. Hmm? Can you hear me now? Hello?
Yes,
Yes, all
yes,
right.
yes,
Okay,
yes.
so I said this PPT is a combination of the other PPTs. And like I said, because it's interesting, I brought it back to you. So we're talking in terms of hemostasis, which deals with the clotting of blood. All right, so this will deal with schematic representation, primary and secondary hemostasis, mortality based on ischemic events, genetic basis of blood coagulation, platelet activation, and platelet function mechanisms. All right, so let's quickly review it. So here we have these tiny little fragments, 2 to 3 microns, with so much power in them, and that's the way I look at it. I'm always fascinated by it. So synonym is a thrombocyte. Resting platelets are round, diameter approximately 2 microns. The normal count is 150 to 450 platelets per microliter. Platelets are formed in the bone marrow. And I think when you saw the maturation from the megakaryoblast to these tiny fragments in our system. So lifespan of blood platelets is approximately 7 to 10 days. A platelet has about 1,000 different receptors. Too few platelets in the blood, we call it thrombocytopenia, which is not a very good sign. Example, due to reduced formation or too fast consumption. Too many platelets in the blood, thrombocytosis. Example, after blood loss or due to hematological diseases. Now, guys, I have always spoken to you about a compensatory mechanism. You're losing blood, your marrow will produce more platelets. You have an infection, your body is going to produce more WBCs. And this is a beautiful example of compensatory mechanism in our body. We can do a whole PPT on this. So here we go, we take a look at it. You've got the picture of the red cell, white cell, and the platelets. And you can see how they travel in the body. There is a motility to it. So blood platelets, when we talk in terms of hemostasis, schematic representation, primary and secondary hemostasis, mortality based on ischemic events, genetic basis of blood coagulation, and I think we've taken a look at these four: platelet activation and platelet function mechanism. So hemostasis, the first slide. So you have the blood flow and you've got vascular injury. So you can see it. You've got the fragments floating around and you have injury. In the second stage, what happens? You have adhesion taking place at the site of injury. Remember? So, four most important functions: adhesion, aggregation, clot formation, and clot retraction. The formation of the clot is as important as the degradation of the clot. Here we go. You can see all these: activation, adhesion, aggregation. And as we go further, you've got the conversion of prothrombin to thrombin in the presence of factor 10, which is activated to give you platelet fibrin thrombus. Aggregation takes place. Take a look. Primary and secondary hemostasis, the two central processes of blood coagulation. In the primary, you've got adhesion and aggregation of platelets, stops bleeding under conditions of blood flow. The secondary is complex cascade of enzymes, the so-called coagulation factors, leading to fibrin formation and polymerization. Yeah, I think we took a look at it last time and we saw how important it was. So that was the physiology. In the disease process, you've got platelet dysfunction, could be myocardial infarction, stroke. So when we are saying platelet dysfunction, maybe the clot is not correct, or you have the clot traveling to the heart, giving you a heart attack, as we call it, myocardial infarction, or this clot can travel anywhere in the body, the brain, etc., to give you a stroke. On the other side, you've got hemophilia, ooh, factor 8 missing, venous thrombosis, pulmonary embolism. So this clot can travel anywhere in the body, especially in the pulmonary embolism, and you can have a problem. And when I think of pulmonary embolism, I think of this friend of mine. She had delivered her second child. I'm talking something like 20 years back. Very dear friend of ours, and very nice, healthy delivery. And then suddenly we got to know that she's rushed to the ICU, and they were suspecting a pulmonary embolism. And at that time, it was so bad we could not save her. I think she was 24, 25 when she died, with a young child, a second baby. In the drugs, oh, there are a lot of them. Acetyl salicylic acid, aspirin, most common. Clopidogrel. Then you've got Prasugel, that's Plavia, or bad brand names and scientific names. You've got Tigarol, that's Bralic, and you've got GP2B, 3A antagonistics like Repro, and so on. And on the other side, you got heparin with LMWH. You know, you've got your coagulation factors, 14 and 15. You got warfarin, very common, especially with heart patients. And you got Dabital. All right, so we're moving movie showing their interaction in flowing blood. So you got platelets, tissue factor, and fibrin. Will the movie work? Or can you want to try it? All right. So this film shows the reaction of the coagulation system to a laser-induced injury of a blood vessel under conditions of blood flow. First, a platelet aggregate is formed, red in color. The red arrow, I think that's the thing. Tissue factor is exposed at the site of injury, green. You can see the green color. And fibrin is formed, a blue color, which I can't look at. Look at the blue color. When the components overlap, the colors white, magenta, and turquoise are used. I'm a little unhappy with this. The mechanism of primary hemostasis, blood platelets, and secondary hemostasis interact with each other. All right. I wish we had a film to show you. Maybe we can a little later on, next week or so. So now we've got myocardial infarction and stroke are the leading common causes of death worldwide. Future trends in global mortality, major shifts in cause of death patterns. And this is a 2008 review. And so you can see 2004, it was ischemic heart disease, cerebrovascular disease, lower respiratory infections, chronic obstructive pulmonary disease, diarrheal diseases, HIV/AIDS, tuberculosis, trachea bronchus lung cancers, road traffic accidents, and prematurity and low birth weight. This is percentage of deaths that we have. The ranks as 1 to 10. And in 2030, this is what we will be having. You can see ischemic heart diseases rises from 12.2 to 14.2. Cerebrovascular disease from 9.7 to 12.1. Lower respiratory tract from 7 to 8.6. You can see there's an increase everywhere. Chronic obstructive pulmonary disease from 5.1 to 3.8. It's gone down a little bit, right? Diarrheal disease 3.6, about the same. HIV AIDS 3.5, about the same. Tuberculosis and all these are on the lower side. Okay, a little descriptive figure. Genetic base is of blood coagulation. During 99% of the existence of Homo sapiens, bleeding risk was high. A strong platelet function was good for survival. So here you can see these guys in uh, skins fighting the bear, and quite a few dying in the process because the bear can really scrape you and make you bleed to death. So genetic basis of blood coagulation. Today the bleeding risks are low, but the risk of arterial thrombosis is much higher. Okay, let's see. Click the button. Okay, so here you got a guy holding on to his chest. The chances are that he is going in for a cardiac arrest. This is low bleeding risk. You got high body fat, higher age, lesser exercise, inflamed calcified vessels with plaque. And your plaques are the ones that give you heart attacks, right? Our platelets are not well adapted to modern lifestyle. We have Stone Age platelets. And this, come back, the plaque is that little clot that is known to burst and give you what today you and I call a heart attack, myocardial infarction. See, look at our lifestyles, Taoism and risk of cardiovascular disease. You've got the monkey man walking, exercise, and now you've got the guy sitting on his TV, dreaming of all those fancy foods, Burger King, McDonald's, and so on. So we come to platelet function and balance. Too little platelet function, severe bleeding in surgery and trauma. That's the reason why your blood count is monitored before surgery. Platelet aggregation in the wrong place, right? Myocardial infarction or stroke. Because these clots can travel anywhere and give you a lot of problems. Ooh. So platelets play a pivotal role for hemostasis following surgery and trauma. And take a look at the purple markings on this guy. I'm sure he's a trauma patient. He's completely hit very badly on the right hand side, and he's got all the tubes going in and out. I think maybe this is a blood coming out from where the injury took place, and you have the CAT scans on the right hand side, and I think there's a problem. No, the liver, the brain looks clear, but there is injury. I think in the on the liver side. I may be wrong on that. I don't go with what I'm telling you. But this is a ghastly sight, isn't it? An accident victim. So main manifestation of arterial thrombosis, myocardial infarction and stroke. So here you can see the narrowing of the blood vessels. And as a result of this, blood does not flow properly, especially through the heart. The picture below says artery narrowed by plaque, and this can give you a very, very bad heart attack or myocardial infarction, as we call it. And especially when doctors see this in the angiograms, angiography, they recommend that either we go in for uh, what do you call a stent, or sometimes if there are too many blocks, they said no, let's go for an open heart. But stenting usually works, and these are medicated stents that do the job. All right. Special risk of arterial thrombosis following placement of stents. You can still have that. Here we go. For the stent placements, different types of stent devices are available. And here you can see A plus B. For elective PCI, bare metal stents are usually used. These stents are pure metals. In case of acute myocardial infarction, usually drug-eluting stents (DES) are used, which are covered with sirolimus or Aciplex to avoid a too fast growing of endothelium, which could lead to a stent thrombosis. So, in spite of stents, you can still come down with problems. So, the last picture can show you thrombosis. You've got drug-eluting stents. You've got partially endothelial status. You have the artery walls and so on. So, it is up to the cardiologist or who's a specialist who will select the right stent for you. And I think each stent goes into lakhs of rupees. Primary hemostasis, importance of complications for complicational diseases. So you have bleeding events inherited due to genetic disorders, which is rare. Platelet disorders, Glasmann's thrombasthenia, Bernard-Solier syndrome, other receptor defects. We've spoken of this. Acquired due to effect of drugs, antiplatelet drugs, or side effects of other medications, antibiotics. Due to disease states, example liver dysfunction, renal dysfunction, bone marrow disease, these are all hematological diseases. Arterial thrombosis, usually arterial thrombosis is based on the change of the healthy structure of the blood vessels, plaque formation, due to inflammation, lipid deposition, and calcification. Blood platelets stick to the vulnerable plaque and leads to myocardial infarction, ischemic stroke, or myocardial thrombotic manifestations. So take a look at this because this is happening in everyday life more and more. Maybe you have some people, your friends, or in the family, and this is a very, very common experience today. All right. Platelets, introduction to platelet physiology, I think you all know. Blood platelets, hemostasis, schematic representation, primary and secondary hemostasis, mortality based on ischemic events, genetic basis of blood coagulation. So platelet activation and platelet function mechanisms are important. Okay. Oh, this is a big chart. See if you can take a look at it. You have the chart with you, right? The platelet possess crucial mechanisms to accelerate their activation. So you've got something called primary agnos, secondary agnos. Then you've got problems with adhesion. You've got an activating change, granule secretion, because your platelets have it, and you've got aggregation. And you've got a whole combination of factors. You've got fibrin, von Willebrand, and so on. If you have the film in front of you, have the PPT in front of you, take a look. So you've got the injured vessel wall right on the left-hand side. And then you can see the changes it can happen in the body. So you can have a problem with your adhesion, activation, aggregation, and problems. I think you also know that some of these reactions require ADP. These are energy-based reactions, especially when you take a look at the platelet on the right-hand side. You've got activated GP2B, GP, and 3BA, and you have the action of aspirin, and you can take a whole lot of things happening. So you've got addition, activation, which leads to shape change, granule secretion, very simply put at that, and you've got aggregation. And you've got the drugs on the right-hand side. You've got clopidogrel gel, you've got prasogel, and you've got ticagrelor. So to sum up, two main hemostasis mechanisms, primary and secondary hemostasis. Primary hemostasis is based on the adhesion and aggregation of blood platelets. Keep that in mind, simply put. Secondary hemostasis is based on a complex cascade of enzymes, coagulation factors, which ultimately lead to the formation and polymerization of fibrin. Just go back to the slide. You can see it in this. If you have the PPT, go back and take a look at this slide. See what happens See how complicated it becomes. All right? Right. So continue. We said platelets are involved in diseases like platelet dysfunction, myocardial infarction, and stroke. After stent implantation, platelets can lead to closure of affected blood vessels, which is called stent thrombosis. Several drugs have been developed which reduce reactivity. Aspirin, clopidogrel, casogel, these are all names which maybe some of you may have heard of it. Tica, I myself have finding it with Tica, Abcimax or Repo, and so on. And you've got several disorders inherited or acquired can cause bleeding events. So you have the drugs that have been developed to reduce platelet activity, and the last bullet is platelet disorders, inherited or acquired, can cause bleeding events. So that is about the last uh, slide that I have for you. Right, right. This was a slide from Horiba that I picked up, and this is a little review of platelets that we've been studying for the past. Today's the third day. Anybody with questions? Anybody? Gautam Bhai, any questions?
Well, okay, fine. Going on nicely.
It's we are giving you a little more information because maybe you don't have it all along. But this is what we look at with the present batch of DMLTs. This is what I teach at least. I don't think the others do. The routine tests that we do are PT, PTT, I think we spoke about it last time. Bleeding time, clotting time, D-dimers. And there are other assays, the mixing assays that I spoke about last time that can be used to correct a factor. Any questions? Anything that you would like to tell us? Nazdeen, are you around?
Yes, ma'am. Here I am.
What all do you do?
Ma'am, mostly PT, APT, then this lab does not have STAGO. Last time in the hospital there was STAGO. So we
Hmm.
are doing mixing studies. We
Yes,
started with
I had said that by mixing, you may have a plasma which is rich in factor ABC, and you have a plasma you have a patient who is deficient. So when you mix that plasma, the PT-PTT comes back into focus, right? Am I right? That's what
yes,
the
yes.
basic simple is relationships that.
Then there is coagulation factor study also that I said last time also. Many because of the population they study the factors also. So
Yes, you can study each factor. That's right.
they are very actually they are very expensive tests.
Yeah,
Uh,
true, true.
and we are having challenges with maintaining the LJ charts and QC because that QC for coagulation is not from 1st to 30th. It is always in between the month or 20 days, 20 days, 20 days. So here we maintain the manual QC also. We do a
Mm,
manual plot also,
mm.
not only from the machine. Then we go into the mu value. We go into what's it called that other one? Two, three values are calculated monthly, and accordingly it is adjusted. The LJ chart is adjusted accordingly.
Are you all familiar with LJ charts? Are you all familiar with
LJ
LJ?
chart.
No, no, let's ask the others. Mm, LJ. What does L stand for? LJ charts.
Levi Levi Jennings, Levi
Levy
Jennings
Jennings,
charts.
yeah, I
Levi
know.
Jennings.
But are you all familiar with Levy Jennings? Where
Yes,
you,
yes, it is.
no, no, no,
Every
no, I'm
day we are
talking, I'm
studying.
talking of the others. Where you work the
Oh,
mean
okay.
SD and CV, right?
Yes, yes.
As I have a feeling we will have to take a presentation on that, or maybe get an expert to do it. I think Parul, you had asked for this, right? Urvi, one of you had asked me for the statistics which are used in the lab. We can do a very, very simple one.
Yeah.
Mean, SD, CV, Levy-Jennings chart, and we also have what is known as the Westgard rules. Westgard has a set of rules, and usually we Saulo said we go in by his first rule, 1 to S. Anything which goes above, but what do you all follow? Nazdin, which one do you keep in mind?
Ma'am, we follow two patterns. One pattern is for single run, single level, one level of the QC that is used, and the second pattern is for two levels of QC which is used.
Because
Two
two levels always preferred.
levels of QC we are using in the morning. Two levels are done in the morning, and for CBC, uh, biochemistry, special chemistry, and
Biochemistry is
immunology.
2 and the CBC is 3. 3 levels.
Uh, we
Minimum.
are we are running one more level in the we are running one time more in the evening.
But that
Now,
depends on
according
the
to
load,
the
ne? What is the load of
yes, yes,
samples? Correct?
yes,
Yes,
yes.
that's right.
And also for accreditation, also they are saying that if you have a high load, then the second run has to be within a period of 8 hours.
Correct.
So what we do is there are two patterns we are using, one 2S, two 2S, one 3S. That is on the first day itself. Two 2S also we are not taking a chance. On the first day itself we are troubleshooting. Then comes uh, R4S. That is the difference of four SDs.
But you
That
allow
means
for R4S?
there is a difference of four SDs. Sometimes it happens. Sometimes we are not getting the SD correctly on the first run also. Sometimes three times also if you calibrate it's not coming properly. Then we have to make new wires. We have to store them again. There are a lot of things which we have to troubleshoot on. So R4 R4S, then 4S, 4X, 7X. For
One
some
side
times
of the
it
mean.
is very unstable. It
One
should
side of
not
the
go.
mean. One side of the mean.
Yeah, yeah. Actually, it should not go on 7X also, but it goes 3X. Sometimes it goes 3X. We cannot troubleshoot on the same day. So in the evening we will troubleshoot. And and on the second, this is for two levels. And one more rule is there: 5 by 5x. Five on one side of the mean, five on other side of the mean. That is for two levels. And if you are running only one level, then that 5 by 5x we will not use. But for all the other levels, we will use 5 by 5x. So that is the rules we are using. But we are having problems when we do the setting in the machine. Nowadays the machines comes that we can fix it in the machine and it will auto reject. But the problem is when it will auto reject, it will reject properly. But you will be using your reagents and calibrators again and again, so it will give you a very high cost.
But
So
don't,
that's
hello,
why
I interrupt
yeah.
you here. Don't you think you should maintain the same thing on your
We did,
charts?
but the costing went very high. Then the management told us we had to stop auto correct. We have to stop auto. What is it called? Auto
Reject.
blocking. Yeah, we had to stop that the QC. So auto rejection. It's called auto rejection. Yes, auto rejection. So we had to stop auto rejection, and we did manually for only three routes then. So because too much calibrate was going, too much reagent was getting used. So management we had to curb down. It was not in our hands. We as part of our performance also we are graded accordingly over here. So we have to curb down on the consumption.
Okay.
So there is a module called consumption under control, which keeps us on our toes. That is the main clash we always have with the management. Also the kits validation when they tell us to change the kits. One another problem is the management. Once they cannot pay a vendor, they will tell us to change the kit with the another vendor. So there also we have to fight. Okay, by my machine is already calibrated now. I've got the system running properly. Because then the new kit again we have to validate that they are not understanding that I have to do the entire validation again. So all the four studies that we are doing, uska costing bhi usko, they don't want to pay also. They are telling to collaborate with the representative and get it done from outside. Now who will do free of charge? Before they were doing, but nowadays no labs are doing free of charge. So the representative is also telling us, no lab is doing what is your lab up to. Then I said, forget it. I can't fight with it. I left it. Always
Yes.
this is the problem. All these years is the problem to get the validation done with the new kit. There is clashes with the management, purchase. They cannot pay. They want us to just change the machine. They want to change methodology. They want to change kits. Coagulation is a headache over here. Real headache.
Yeah, I can understand your point of view. I can understand your point. Anybody else? Any other questions? Farizad, what have you been in touch with the lab stuff? Farizad, are you hearing me? Unmute. Hello. Uh, Shabana, are you on?
Hello?
Yeah.
Hello? Yes, ma'am.
Farizad, are you
I'm not in touch, ma'am. I'm not in touch.
you're not in touch. That's what I thought. Okay. Okay. Who else was there? I think Parul, you wanted something on lab statistics, right? We'll do
So
it.
I want. Uh, so I said that I would like to come to your lab at some point and interact and then see what, because I haven't been for a long time. So
That's a different thing. That's a different thing. But like I said, maybe we can run one short 40-minute on lab. This being SDC, as she was talking in terms of
yes,
Westgard rules, we're talking in terms of how to maintain these statistics. And like she said, you have machines now that have the Westgard rules. So you have to program it to accept or to reject. So you have to make up your mind what you're going to accept and what you will reject. Also, a good
okay,
idea, little bit of gaddai vetru as we call it, to maintain this Levy Jennings chart on your
okay,
doc paper. You know.
yes,
This SD setting is also very challenging. Sometimes we have to take 60 points, sometimes take point. Sometimes we don't get enough samples for coagulation. So if you need a good SD, then you have to wait for lot of time.
Yeah, but Nasin,
It's
I know
also very
coagulation is a very
challenging.
tricky subject,
Yeah, normal
but
biochemistry is okay, no problem. You can get the
biochemistry, hematology
equipment
is no problem. Because otherwise, how will you go into proficiency testing? How will you go into external quality control? You need all
yeah,
this thing.
technology, no problem.
Any other questions?
But we have CAP,
Okay. We can't hear you. You're
we have
unmuted.
BioRed, we have Recast, we have CAP.
I think a very common here is Biorad for Equas.
Yeah,
CAP is also getting to be very popular.
Equals.
And you've got the other bits,
And it's
UK.
actually CAP is very nice. The CAP reports which come now, they are very standardized and they are very nice. They have got history, they have got this histograms. CAP is much more standardized, I feel,
Uh,
for hematology, coagulation, for everything. CAP is good.
Mahesh is getting. Uh, yeah, I agree with you. But like I said, this is an expensive process. Joining in Equas is expensive
Yes,
anywhere.
yes.
It doesn't matter which company like Biorad, you've got CAP. I know CAP runs to lakhs of rupees for the year.